Okay, thank you very much. It's a pleasure for me to give a short presentation on the diagnosis and treatment of nocturnal hypertension. As you may see here, if we compare two different populations from Europe and Asia, then we see a smaller nocturnal blood pressure fall in Asians than the European people, regardless whether they are from Western or Eastern Europe. So that's actually why we studied nocturnal blood pressure and defined a isolated form of nocturnal hypertension. You see some people had actually very normal daytime blood pressure, but elevated nighttime blood pressure, which is defined as 120 over 70 millimeter mercury and higher. Then if you then look at the prevalence of those people with isolated nocturnal hypertension, it was more than 10% in China. Then if we compare with other populations from Japan, South Africa, and Western and Eastern Europe, then you see quite different prevalence in these different populations. In Chinese and Japanese, we had much higher prevalence of isolated nocturnal hypertension than European people. And then if we look at the prognostic value of nocturnal hypertension in comparison with those people with isolated daytime hypertension, normal tension, or day and night hypertension, then you see those people with isolated day and night hypertension, they had a very similar risk of cardiovascular events. So it means that even though they had only mildly elevated systolic or diastolic blood pressure during sleeping hours, they actually had increased the risk of cardiovascular events. So we know nighttime blood pressure is important, but we still often have problem in the detection of nocturnal hypertension. Here you see if we perform 24-hour blood pressure monitoring in different seasons, then you see that in contrast to our belief, blood pressure was lower in summer than in winter. Actually, here you see blood pressure during sleeping hours was actually higher in summer than in cold seasons, especially in winter. So we actually have a misperception, and blood pressure always is lower in summer and in winter, but actually here you see a very different scenario. And then if you look at whether such elevated nighttime blood pressure was associated with risk, then you can see that nighttime blood pressure during summer was actually associated with the risk of target organ damage in the kidneys, in the arteries, and also in the heart. So it means that such a masked nighttime blood pressure elevation actually was associated with the risk of target organ damage. Then we still face very serious problems in the management of hypertension, especially when we take into account season and 24-hour blood pressure control. Here, if we look at daytime, actually clinic blood pressure control, so you see it's true. If you start treatment in winter, then you would reduce blood pressure more than you start treatment in summer, because you tend to increase your treatment intensity. Then you would have a much greater blood pressure reductions in autumn and winter in comparison with the spring and summer. So you see the difference was statistically significant, can be up to 7 millimeter of mercury difference systolic blood pressure and 4 millimeter of mercury difference in diastolic blood pressure. Then if you calculate the control rate of clinic blood pressure, you see a much higher control rate in those patients who commenced antihypertensive treatment in spring and summer than in autumn and winter. So it means that if you rely solely on clinic blood pressure, then you probably increase your treatment intensity in winter than in summer. Then you would have a greater blood pressure reductions. But if you then treat patients, then look at 24-hour blood pressure lowering, you see a very different scenario. So when you treat in winter, so you treat more intensively, you have greater nighttime blood pressure reductions than in summer. So it means that in summer, you treat less intensively, then you would have a higher nighttime blood pressure, as we have observed in previous studies, and which was actually associated with a higher risk of target organ damage. And here again, you see a comparison between spring, winter, and autumn. Spring and summer, and autumn and winter, and you see a very significant difference, especially at 8 weeks of treatment. Then you see a different prevalence of non-dipping pattern after treatment, and you see a higher prevalence in spring and summer and lower prevalence in autumn and winter. So it means you treat less in summer, then you would have a higher nighttime blood pressure. So that's why you would have masked nighttime hypertension. You would also have masked nocturnal hypertension, because your treatment is relying on clinic blood pressure solely, and clinic blood pressure is usually measured during daytime. So finally, I would discuss a little bit of treatment of nighttime hypertension or nocturnal hypertension. So if we want to treat nighttime blood pressure properly, and of course we can do 24-hour blood pressure monitoring and treat patients according to nighttime blood pressure. But it's not always possible to perform 24-hour blood pressure monitoring in many patients. Of course, even more difficult in all patients with hypertension. So we probably can just use those drugs with more efficacious nighttime blood pressure lowering effect. Here you see we now have the so-called ARNI, neprilysin angiotensin receptor inhibitor. When you use this drug, then you see a greater nocturnal blood pressure lowering effect and better control of nocturnal hypertension, as we have seen in this study with sacubitril valsartan. And then we observed very similar results in a recent trial with sacubitril alisartan. Here on the left hand, you see 24-hour blood pressure reductions, and in the middle, it's daytime blood pressure. On the right hand, it's nighttime blood pressure. Then if you compare the daytime and nighttime reductions on the 3 different treatments, So on the left hand, you see two groups, two dosages of sacubitril alisatan. Very left, that's low dose, 240 milligrams sacubitril alisatan. In the middle, 480 milligrams of sacubitril alisatan. On the right hand, it's olmesartan, 20 milligrams per day. Then if you simply compare these three different treatments, then you see that the nighttime reductions on sacubitril alisatan actually was significantly greater in those patients treated with sacubitril alisatan than olmesartan treatment. And if you then compare daytime and nighttime reductions, actually the reductions in nighttime blood pressure were much greater than in daytime. So you see here, if you use sacubitril alisatan, you would probably achieve a much better nighttime blood pressure control in those patients with hypertension. And another drug was just approved in the United States and Europe. Here you see very similar results. Actually, that's an endothelial receptor antagonist, aprocitentan in resistant hypertension. Here again, on the top is 24-hour blood pressure profile. You can already see a greater nighttime blood pressure reductions when you use aprocitentan than placebo. Then if you look at the reductions in these three different groups, two groups of aprocitentan with two different dosages, either 12.5 or 25 milligrams per day, then the blue bars are for placebo, then you can immediately see the very significant different results between these two dosages of aprocitentan in comparison with placebo. So here again, you see a much greater blood pressure reductions with aprocitentan during sleeping hours than in the daytime. So you see again a greater blood pressure lowering factor at night with this new drug, endothelial receptor antagonist. And with the emerging technology of renal denervation, you can also see something very similar. Actually, in this study, they also observed a greater blood pressure reductions during sleeping hours or early morning hours. So it means that this device-based therapy had also a greater blood pressure reductions during nighttime than in the daytime. So we may conclude that nocturnal hypertension is very common actually in all populations, even the isolated form. And the prevalence of nocturnal hypertension, of course, also isolated nocturnal hypertension is higher in Asians than in Europeans, probably because Asians tend to have a higher sodium intake and sodium sensitivity. And nocturnal hypertension is very often masked, especially in summer, because you tend to reduce the treatment intensity and leave nighttime hypertension uncontrolled. But these days we have novel emerging treatments. Probably those new treatments can be very efficacious in management of nighttime hypertension because apparently this new treatment can reduce nighttime blood pressure more effectively than during daytime. Thank you very much.